Welcome to the podcast where we discuss health, health span, lifespan, and longevity. I'm Dr. Noor Gajraj. Okay, welcome to the podcast. We're going to talk about a very important subject, Alzheimer's disease. I was just looking up the incidence and it said 11% of people over 65 have Alzheimer's. Anyway, we've got an expert to talk about this, Arwen Podesta. She's boarded in psychiatry, addiction medicine, forensic psychiatry, and holistic and integrative medicine. She works in Louisiana with an office in New Orleans. She's authored a book on addiction called Hook, which is very good. I've read it myself. She was recently awarded the honor of Distinguished Fellow of the American Psychiatry Association, as well as the American Society of Addiction. So anyway, thanks very much. Tell us, what your approach is to patients with Alzheimer's.
Yeah. Listen, what we used to say was that about 1 in 3 people are affected in some way by Alzheimer's, right?
Yeah,
Because, like my mother actually, and you were saying that you have a
sister-in-law.
family member. Yeah. So like we all have, not all, but 1 in 3 people have someone that is affected by it, that is suffering from dementia, Alzheimer's in particular.
Yeah.
And I reframe it because you do lifestyle medicine, and that's my take on the world, that we should be able to identify modifiable risk factors
Mhm.
that are modifiable and rethink the way that we have like this death sentence, or this like more morbidity or mortality sentence with the diagnosis of Alzheimer's. And I want to think about, I just got, like 5 minutes before you and I got on this meeting, I got something from Medscape, Medscape is one of our, email listservs. They store a lot of really great data, a lot of new information. And it was a question about a new type of treatment for Alzheimer's. And the question was, I'm going to read it. Which of the following is the primary goal of treatment for the patient in early stages of Alzheimer's disease? And what do you want if someone has a disease? What do you want if someone has kidney disease or has, a lung infection? We want curative healing. We want, a whole bunch of, if someone has psychiatric issues, and that's what we talked about before, is turning it into treatment. That it means actual treatment, not what Medscape is saying, which the proper answer was. So these were the questions. Clearing Alzheimer's disease pathology from the brain
Mhm.
was one option. That's what I want.
Mhm.
Preserving independence for as long as possible.
Mhm.
That was the answer. It's not reversing cognitive decline to a previous stage. It's not clearing pathology from the brain. And that troubles me because I've been watching, and I'm not the premier expert in this by any means. Some of my mentors and colleagues in this field are doing the research and have done the research, have written the books, and about cognitive reversal. So when we get into early and moderate stages of Alzheimer's, what we have in the brain is basically, I can consider it kind of like scar tissue. It's brain injury, but it's just all of the brain pathways being clogged up with what we've called plaques and tangles for a long time. Amyloid plaques, p-tau, biomarkers that are really scarification. Just like when we, have a cut on our body, we might have a scar, and that scar might last a long time, or that scar, if you do it right, could be reversible, right?
Right.
If you use the proper cream, if you use the proper maybe physical therapy, if it's an internal scar, if you use a whole bunch of anti-inflammatory type of things, then you can help prevent it. And so what I am intending to do with our talk today is try to demystify the idea of dementia being a life death sentence, that it's a straight path down,
Mhm.
because you've seen it. I've seen it, and it's sad. It's depressing. It's You feel helpless when you're watching someone go through decline. You feel, when the person is going through the decline, they might not have noticed, but they come off as very irritable because they're losing parts of their brain function.
Mhm.
So that's what I'm here to talk about. And
Right.
that's what my program is about. My program is actually I have a lot of patients. I do treat folks with dementia, but I unfortunately treat many of them with traditional means just because they're already in a state. It takes a lot of motivation and supports when someone's already in moderate dementia to do all of the testing and all of the things to figure out how we can perhaps reshape the brain,
Mhm.
defrag the hard drive, as it were.
Yeah.
But my program is really for people who have a family history
Mhm.
of dementia,
Mhm.
watching someone suffer, and they want to know what they can do to modify and prevent.
Okay.
Because there's definitely causation that's related to inflammatory things. There's definitely causation that might be, or correlation, or heavy weight on if someone has ApoE44.
Mhm.
But not everyone with ApoE44 develops dementia. And
Right.
why is that? What you and I know is that, genetics plus environment have this epigenetic phenomena. I think I even said this before. We can't change the color of our eyes. That's like one gene, no epigenetics. But we can change certain risk factors for certain diseases, even if we're partially prone to them, just like diabetes.
Yeah.
We think now we have diabetes is a reversible disorder. 30 years ago, 10 years ago, in my medical school training, and I bet yours too, we didn't think that it was a reversible disorder,
No.
right?
Right.
So, yeah, so that's where we are. So I want to mention that there are some really neat new medications. There are old school medicines for, like, when you and I were in med school and in our early career, we were using Aricept and Namenda. Those were the mainstay, and those work on NMDA receptors and acetylcholinease inhibitors. And their goal, like I asked in that question, their goal is not to improve cognitive faculties,
Mhm.
but their goal is to reduce the quickness of the decline. So instead of having the slope going this way, to have the slope go less steep.
Right.
So that's, we have that in certain cancers, we have that in certain other things, and I get that utility in medicine, but if we can do better, we should do better.
Right.
Some of these new medicines are actually combinations of those, but then there's a couple of new ones that are infusions, IV infusions, that are anti-amyloid. So what we've said is we've got amyloid in the brain.
Right.
Tau is really the biomarker in there. And we can make an anti-amyloid monoclonal antibody that clears the plaques.
Right.
So that's so exciting because
Yeah.
that actually is ostensibly, those who I know that have gotten this in the clinical trials, yes, in fact, it does help keep the slope from going down, but it actually brings back memories and brings back functionality,
Right.
not to 100%, but if imagine if you had a brain shaped fish tank
Mhm.
and you had fish in it
Right.
and it was full of algae and the fish couldn't swim around and get their food, and then you were able to clean that algae out, guess what, you're going to have higher functioning fish.
Right.
So that's how I'm thinking about it. um any particular, like, I want to go over some of the modifiable pieces because I think of it as a, just like everything in our functional medicine, longevity medicine, it's kind of a supply and demand phenomena,
Right.
right?
Mhm.
the supply that we have, I saw you, I actually watched your podcast that you did on NAD, nicotinamide adenine
Right,
dinucleotide. I use that all the time, which is a cellular anti-aging essentially,
right.
by helping clear the junk, replenish and refresh. It's like cleaning out your computer. I just brought my one of my old laptops to the you fix it place to have it all defragged, and now it runs a lot better.
Well,
So that's kind of what NAD does, enhancing sirtuins, enhancing BDNF, brain derived neurotrophic factor. And we have natural NAD, and it declines as we age.
mhm,
And so our supply of that and sirtuins and all these other protective factors goes down as we age. And demand might be stacking, whether it's demand stress, is demand um, blood flow need,
mhm,
is demand nutrient, like overcoming nutritional deficiencies, hormone changes, um, is demand your body trying to go against and fix all of the damage being made by all of the inflammatory things, whether it's mycotoxins, dental infections.
mhm,
There's so many things that place demand on our body. Our stress with our phones, our stress with our jobs, our
mhm,
stress with our family, our environment, environmental toxins. So if your supply is going down and your demand is going up,
mhm,
you're going to have some damage that could be inflammatory. And oftentimes, inflammatory could include neuroinflammatory.
right. Yeah. Okay.
Metabolics as well, and this is where we think that I love this. There's been some research, really minor, it's still in the working stages, and maybe you know more about this than I do, but the GLP-1s that are being used for initially FDA approved for diabetes and now being looked at, or now being used for weight loss.
Mhm,
But those optimize your carbohydrate balance and your metabolic and insulin and glucose balance,
right,
which affects your brain cells as well.
right.
So that all together minimizes inflammation. And so there have been a couple of reports written related to dementia and using GLP-1s in the preventive phase.
One of the mechanisms is, as you said, control of glucose, because a high glucose is a risk factor for cognitive decline, right? Together with hypertension. And I'm sure you're going to say, I mean, one of the things to do is to make sure you've got good control of your glucose and, treat hypertension. Sorry.
And that's a whole nother thing. Yeah, but back to the metabolic profile is what we know is thinking about, like, do you use much of the ketogenic diet for some of your patients?
No, I don't do that. But I did hear that it can be really good, maybe from you, for depression. Right.
Depression, brain health in general, and so one of the protocols that has been studied most widely for actual cognitive reversal, and I'm happy to review one of the recent studies by a tremendous mentor and friend named Dr. Toops out of San Francisco. They have been optimizing all of these pathways, including metabolics, and using ketosis, mild ketosis,
Yeah.
for those who can tolerate it. Not everyone should do it, but using mild ketosis in is just very enhancing of brain health in general. And part of it is that glucose as a fuel, when you're using glucose as a fuel, it can be highly inflammatory.
Right.
And so when you're using ketones as a fuel, which is what a mild ketosis does, it takes it, instead of using glucose as a fuel, it uses ketones as a fuel. That then turns into a situation where you're actually clearing inflammation.
Right.
So I think the last time I talked to you, I did like a challenge with some of my patients to do a month of ketotic diet,
Right.
and I was just like sharp, and I felt like I was 20 years younger, and I didn't check my metabolic age at the time, but I'm going to do it next time. because it really is enhancing, not hard to do. But that's not what we're here to talk about necessarily today, but that just lends to the notion that optimizing your inflammation in your brain through diet in particular is a one key factor that factors in. Now, if someone optimizes their diet, takes their blood pressure medicines, reduces their stress, optimizes their sleep, exercises 3 times a day, and yet have a high mold or something like someone I know is highly susceptible to cat allergies and yet is living with a bunch of cats right now and has been for several years. And so her inflammatory response is really high and chronically high right now. If she does all of those other things and still has this thing that's causing her to have inflammation all day, every day, or if you have mold in your house, or if you have been exposed to Lyme disease or other sorts of, we know very well that like certain viruses in particular, but we've seen it in cohorts, not necessarily for dementia, but we've seen it in cohorts with COVID, that a lot of people have gotten long-term, they call it long haul COVID, but it's long-acting neuropsychiatric issues that often include brain fog and decline until they're better. So their body is, trying to right that supply demand, and the demand was really, really high and the supply was low because the immune system was fighting off everything. And so the body naturally tries to right it. But if you're constantly bombarded with the same exact, or not with a stack of multiple inflammatory toxins, then we have some concern. So a whole nother thing is what I think of in my family, though there has been Alzheimer's, dementia in my family. And so I'm paying attention to it a lot. And I know very well that we're much better at optimizing hormones these days in women and men. And in women, there's a lot of noticeable decline cognitively right at between 5 and 10 years after menopause. And that's when we start losing brain cell health, or healthy populating of the brain cells. And so thinking about that, I want all of my patients that can be on hormone replacement, or at least hormone botanicals that can help with hormones and hormone balance. I want them to at least be aware that that is something that they can use.
Yeah, I do know that optimizing hormones will improve cognitive function. But let's say you have a 65-year-old. Do you think replacing estrogen would help if they've got Alzheimer's? I mean, have you done that and seen much of a...
So good. That's a great question, and this is where, so I would want to pay attention. I would want to look at the hormone levels,
Yeah,
see if they were not optimized.
right.
There's this discussion, and many of my really talented hormone physicians, they are comfortable replacing hormones 10 years after menopause,
Yeah.
but the general societies say not to.
There was just sorry, but there was
Yeah.
a women's health initiative study that showed that there was an increased risk of heart attack, strokes. Yeah, it was
Yeah.
the whole study was found to be flawed, and they actually wanted it to be retracted. And that's unfortunate because a lot of people think, oh, heart attack, strokes, um,
Cancer, there was the risk, the
cancer.
part
Yeah,
of part of what a lot of people, because that study was published in 2000 or 2001, I believe,
right.
when I was in medical school. So so that was what my entire cohort believes. And so it's something to kind of think about differently when we can, and we know a lot more, because also the part of the flaw of the study was that they were taking oral contraceptives or taking Premarin or Prempro. And part of going through the liver is certainly a concern with how it's metabolized. So the newer hormone replacement therapies are things like creams and topicals, and maybe one like progesterone goes in the body, but everything else goes on the body. So
Right.
it doesn't go through the liver, which means that it doesn't have that separate thing. Because a lot of the story is that when your estrogen and progesterone shift and you no longer have a menstrual cycle, that you get changes in mood, brain, cognition, concentration, hot flashes. So as a psychiatrist, a lot of, you know, 45 perimenopausal to 65 full menopausal women come to me saying, I need a psychiatrist because they're having new onset insomnia, changes in mood, depression,
Yeah.
rage, irritability, all of these things. And so when they come to me, I go ahead and test hormones, and I work with a couple of gynecologists to make sure that I'm not missing anything. I actually have usually refer to the gynecologist to help prescribe really in a nuanced way.
Mhm.
But I find that, if listen, Nora, if someone didn't need me, I'd be very grateful. If someone didn't need a psychiatrist, I think that's a win. I don't need the business. I mean, I don't not need the business, but I don't want it
Yeah.
to be as a business. I want the person to get healed. And that's what happens a lot when we get hormones balanced. So that said, in the 65-year-old range, yeah, I mean, from a theoretical case, I would certainly do a deep dig and look at all of the aspects from hormone levels, hormone balance, metabolic balance, homocysteine, other pieces. And I have
Yeah.
on my coursework, I have kind of all the things that can be ordered, and then figure out if those things are not optimized, optimize them. And if those things are optimized, then look deeper, because we can do mycotoxin tests. We can do organic acid tests. We can do a whole slew of other tests to see if we have some pieces that are putting the toxic load high.
Mhm.
And we have the means to reduce that load if we remove the toxin, right?
Mhm.
So that's the beauty of it. So, and then there's things like taking certain supplements that seem to make a dent, but I wouldn't try I wouldn't try a slew of supplements first without doing the testing, because sometimes a supplement is like I don't know, like something like it's barely touching it, because you're going uphill so hard against the toxins, or going uphill so hard, like if you don't have estrogen anywhere and you need it to make your brain synapses fire, taking huperazine or cetocalline is not going to suddenly, it might make a little dent, but it's not going to suddenly make your lack of hormones better.
Yeah. There are a couple of oldies I was thinking about the other day. Fish oil,
Yeah.
cognitive improvement. And, one that's been around for decades and spoken about, ginseng. I was looking at a Cochrane review, and
Uh-huh.
there are benefits for cognition. So,
There are, and yet, if someone, not for everybody, right? So and I mean, I think that a preventive tool is always going to be make sure that you are having enough omega fatty acids in the right balance in your system, the omega-3 4 times or 6 times as much as the omega-6. And also, curcumin is a good one. That's in
yeah,
turmeric. And so we know that people with a high turmeric diet have, but there's also some genetic factors that go with that we haven't really been able to suss out. Um, Optimizing your thyroid is another part of the hormone cascade, right?
right.
Ashwagandha, lion's mane, bacopa, magnesium, those are all things that have been known to have some very good impact. But again, if someone is, I'm trying to think of a good analogy. If someone, I don't know, never mind. But if someone has a pretty severe injury, then using um, ibuprofen isn't going to heal
Right.
the
Yeah.
injury. Like, so if someone has a significant toxic load, such as a cat allergy, a gluten allergy, a highly toxic, moldy environment, a moldy environmental load because of wherever they live, then these things might make a small dent, but they're not going to cure the underlying problem. And that's what I like about the studies that Dr. Toops and Dr. Dale Bredesen have done and brought to the table, because they really look at, Dr. Bredesen talks about it as like, I think he calls it a 38 prong hypothesis, which is why it's so hard, because if there are 38 holes in the roof, is the way I first started studying some of his coursework in about 11 or 12 years ago. If there are, 38 prongs in the roof, and you cover 38 holes in the roof and you cover one hole,
Yeah.
still have the water seeping in elsewhere. And so that's the tenet of integrative or functional medicine, is to do all of those things around the same time. But sometimes we have to test to understand which we should do first, or if we need to do all, or how not to overburden the patient as well.
So in terms of decreasing the load, the amyloid load, obviously we've got monoclonal antibodies. They're designed for that, so I'm sure they work to some extent. But what else targets the amyloid specifically, or is there nothing else, or is it just a matter of cleaning up the environment so the synapses have less, I guess, obstruction, if you like? Are there any other
Yeah,
drugs?
that's really the tenet. Like, it is true that that decreasing the amyloid would be an ideal setting, and that's amazing that these monoclonal antibodies do exist now and are available. By the way, I would like to mention that they are in the tens of thousands of dollars per
Yeah.
infusion, and so it's it's something that that we're looking at, and I'm sure that that will change in the long run. But I want to think beyond the amyloid hypothesis, because as far as when someone already has the scar tissue, what can we do to decrease the scar tissue? It is a lot of anti-inflammation type of stuff. But remember, amyloid is like really the end effect. It's not the cause. It's the cause of the ultimate decline that we see. But if we can find it beforehand, then we can both reverse it and prevent it. So because amyloid is so difficult to on the brain cells. And what we know is that the reason that ApoE4 is, reminder, like amyloid is basically an immune, like an immune deposit, like when the
Yeah.
immune system is overactive. So our job is to make the immune system calm down, remove infection, inflammation, etc. So that's what I was thinking about when I was talking about, like, viruses and toxins and air pollution and all of these other things that we know that cause that sort of reaction. So I like to think about prevention, but I do think that some of the factors that we want to address um, are the anti-inflammatory stuff, from ketone, after testing, from ketone diet to making sure the mitochondria are highly available to do their job, because any degenerative disease is going to influence the mitochondria, and that's why NAD is so amazing. We did a couple of, I did a very small not head to head, a very small study doing a couple of infusions of high dose NAD for two sisters with Alzheimer's,
Mhm.
both with moderate to severe. And it was impressive that both of them had mild. I used, and we only did it like 5 infusions. It wasn't a multi-center study. It was just kind of more of a, like, is this a proof of concept we should start paying attention to? And it was probably 8 or 10 years ago. But I did CNS vital signs, which is a cognitive testing. It's a computer-based cognitive testing neurological test that does like the Stroop test, the go no go colors and shapes, and it's like a very the speed of hitting the lever. So it's a pretty universally used neurological cognitive test to see improvement in things. And although the two people did not have marked improvement on the outside cognitively, their cognition tests by this marker improved. It was transient. It probably lasted 4 to 6 months, but that in and of itself was enough for us to say, we do think that NAD alone can help the cells at the level to help reverse some of the damage, particularly in the mitochondria, is what we're most enthusiastic about. So that said, there were other ancillary benefits to some of these, to these two women's health. One of them, her urinary incontinence went away forever, something that she'd had for over a decade. One of them, some of her skin, she had psoriasis, and some of her skin stuff was never to be seen again. And I don't know if she has it now, but that was a very long outcome of cellular repair and immune repair, and basically like reducing the toxic burden by increasing the supply.
Right. So we've got, yeah, and that's why, you've spoken a lot about inflammation. I mean, I think a lot of that is related to blood glucose and added sugar. Um, I've been putting together some recommendations for how much added sugar you should, and it's pretty low. It's like 36 grams, something like that. 1 can of Coke has got 40 grams of sugar, all these candies. So you can get, I mean, added sugar, you can get up to high numbers very quickly.
Really quickly. And it's not really measured in your blood glucose yet
Right.
because your kidney's doing its job. But I can tell you it's absorbed cellularly and it's affecting your brain for sure. I have one cousin is a science teacher for high school, and she does exactly that. She has everyone, all the students bring in all of their favorite
Yeah.
sports, favorite drinks, whether it's a sports drink, a Coca-Cola, a Diet Coke, whatever. And she has a whole bunch of scales, and she'll be like, okay, let's look at what's in this. And 40 grams. And so she puts it on the scale, and the students are just overwhelmed. And there's a marked shift in their intake after that.
So your approach is really, which is very interesting, not focused so much on the amyloid. Clear as much of it as we can. There's no blockbusters, is there, in terms of amyloid itself, but creating a better environment. Kind of you've got the problem, but let's try and make the neurons as healthy as we can and as functional as they can. And I guess if you do all these things, you would get quite a bit of benefit. But what do you see in, if you give us a picture of somebody that comes in, let's say they're 60 and they've got a poor memory, can't remember much from 1 minute to another. Do you see, how much improvement do you see? Sounds like you can see quite a bit of improvement.
So here is the very problem is that that patient
Hmm.
um, may not be able to make the decisions to eat the food appropriately, to follow through and be adherent to all of the things. Because when I tell you it's again, I don't know the number, 38 prong hypothesis,
Hmm.
it's a lot of interventions, a lot of sometimes supplement taking, a lot of, let's say, if you have mold and toxicity in your home, removing the mold, on top of that, taking a binder or doing something like that. So it's a lot. So if they have a great team around them, then they can usually get to kind of a moderated space and maybe some like little windows. But in an outpatient setting, unless I had like a specialty group and a home, like a home care team, like Dr. Toops and her study has, and like Dr. Bredesen, which has a company called Recode, RECODE. There's also inpatient settings that are doing the whole package, all of the testing and all of the treatment together. then you can see some significant change. And in fact, Dr. Toop's most recent study called Four Winds, let me make sure I get the numbers right. Um, they had the it was a clinical trial, and it was published in Aging magazine, Aging journal, and they had 84% improvement. So pretty significant and pretty impressive, but it takes a lot of work, which is why my tactic at this moment is referring to people like her and to Dr. Bredesen's team and to inpatient if we can find it. But my tactic is working with people who want to know their likelihood and then how to reverse it or how to prevent.
I watched a TED talk. This lady was talking about coconut oil, and she was
Mm-hmm.
saying it was dramatic.
I
What do you
love it.
think of that?
Yeah, that's the
Coconut
MCT.
oil?
And so,
Yeah.
yeah, that's medium chain triglycerides. It's really helpful for all brain health, a teaspoon a day. Some people say a tablespoon, but you can see some dramatic results. But again, if you have a neurotoxin that's in there that's causing inflammation, you're going to get this much result, whereas removing the neurotoxin. So that's why I work with wanting to think about testing and removal, but also enhancing all of the neuron and mitochondrial function with some of those supplements and some of those tools, the dietary tools.
So I am going to look into the subject of acute mold toxicity. I don't really know much about it at the moment, but can you get mold toxicity just in a regular house and you don't know it's there?
Sometimes it's kind of depending on the location and where you would be, what sorts of molds. Certain types are worse than others. Your basic outdoor mold, it doesn't have that much that gets into the system. We know very well. Like, let's think about medical school, aspergillus. That's terrible, right?
No.
So that can cause pretty severe brain disease because it causes an infestation. And so, what we're worried about is molds that can cause infestations. And so, I don't think that every mold has that. And I am not a mold expert. I have a great mold expert for you. Um,
Okay, great.
yeah, yeah. So, top notch. So, I'll put you guys in touch because I'm very impressed. So, I think that there's a lot more we can do. And seeing that questionnaire, like what's our goal with loved ones that have Alzheimer's or with patients that have Alzheimer's to keep them well enough. I don't buy it. And I think that a lot of our new ways of thinking about this disease are shifting.
Right.
I want to make sure that people know about this. There is an inpatient place, I believe, that is in Kansas, that is using the methodology that I'm speaking of. And I've referred a couple of people there. And it's called Marama, or Marama, and it's doing the Dr. Bredesen's Recode protocol all in under one roof, which is pretty impressive because, like I said, if you're doing it with no help, or if someone is trying to do it themselves, or a daughter or son is trying to do it themselves, it's overwhelming
Hmm.
and really really hard. I don't suggest that you shouldn't try it, but it's very hard.
Do you have any tips about how to deal with somebody, a partner that's got Alzheimer's? Because it can be very stressful for the
Very stressful.
caregiver,
I
right?
Yes. You know, it it is so necessary to have support around you
Hmm.
and loved ones, but also help. There are support groups. There are care trainings. Each state has an Alzheimer's website with an Alzheimer's association. And so trainings on certain things to do and that benefit someone with dementia, because regardless of if we try everything, if it works, that's amazing because it does work. Like Dr. Toop's study for 84% of the people that were intensely treated.
Mhm.
Um, but that 16%, or for those that don't have the means to do that, we are looking at a pretty difficult illness regardless, and having the knowledge and the supports is imperative. I think that hiring caretakers or being able to have caretakers that are that are knowledgeable of um, what dementia looks like and how not to, because a lot of times caretakers kind of get for dementia patients, that when dementia patients get irritable, caretakers don't have tools or haven't been trained. Even loved ones that are caretakers, they don't have tools or aren't trained to know what to do, and so they push back or they make it more they kind of engage in a way that is not recommended. And then there's little tricks like,
Mm.
if someone doesn't know what day of the week it is, making sure that there's a big calendar and that somebody in the household X's off the day when it's finished. Little things like that, just little orientation things. Where's the trash can? Put signs all over the house for certain things, because oftentimes when someone with dementia is irritated, it's because they're frustrated and sad and they aren't able to be independent any longer. And so helping them stay independent, like that question said, helping them stay independent is really important.
Excellent. Well, we got to the top of the hour really quick. I mean, that was
Wow.
fascinating. Yeah, I mean, gives me a lot to think about. Probably have to get together and go over some of these things again. And, I'm really thank you because it's a really big subject. Even if as a doctor, I don't treat Alzheimer's. So, I was I didn't have a very good understanding of all the ins and outs of it. So that was really helpful. I think people watching this will be really benefit from what you've said. So
Thank you.
thanks, Owen.
Yeah, thanks for your attention to this matter. I think that you have a wealth of information through your podcast, and I think that Alzheimer's is a really important thing. And like you said, it affects that many people, 1 in 9 or 1 in 11. But you probably do treat people that have individuals in their family that are suffering.
Yeah, I would think so. I think everybody knows somebody with Alzheimer's. Everybody knows someone with addiction. Uh,
That's right.
as before. Okay, well, thanks very much. We'll get you back for another topic. I'm sure you have a lot
Great to
of
see you.
knowledge I need to tap into.
Oh yeah, I can't wait. All right, take care.
Please subscribe to my channel and read my new book, 100 Pathways to Longevity. Add 25 years to your life. Available on Amazon.